we ready to start? Is everybody ready to start?
Yeah.
As ready as you're going to be, anyway. Yeah. Well, somebody's microphones.
No, but
Yeah, we are live. Okay.
it will be pushed. That's horrible.
Are you ready for us to go? Yeah. Yeah. Should we just get going? Yeah.
It's hard to say
Yeah, I
much
think
in
we
3
just
minutes.
start. Yeah.
Trying to figure out how
Otherwise,
to make
yeah.
1 or 2 points
Yeah.
and then get out.
Yeah, I'll just. Yeah. So, good evening, ladies and gentlemen.
Doesn't work.
Hello. Okay, can I suggest we start this session? First of all, we'll go through some introductions, but before anything else, there's a task for all of you, which is when you get back to your offices, you should print yourself off a certificate for endurance, for still being here with us so late on day one. So I'm Professor Sir John Strang. I'm based in London, the National Addiction Centre, and I'm really grateful to what I would still regard as the MCDDA, but I know has got a different acronym now. Really grateful for them putting together this debate, looking at the issue of drug deaths, and also asking questions that challenge ourselves about with the numbers of drug deaths continuing to be high, and not just continuing to be high, but escalating, which aspects do we feel have been valuable, and where do we think perhaps there's less impact than we had anticipated? Hopefully then finding areas where we think there could be more intervention that would be of benefit. So the topic we're going to be looking at is, why are we not doing better at reducing drug-related deaths? Now, we've got a really, well, certainly I feel we have a really interesting panel from across different parts of Europe, also across continents, so from Australia and from the US. Also from very different professional backgrounds. So I hope that in the contributions that we have, we'll be able to integrate those different perspectives. My biggest challenge is going to be getting each of the contributors to stick to the 3-minute contributions that we've assigned to them, because I'd happily listen to them for a lot longer than the 3 minutes that they're going to have. So I'll now ask people to go through introductions of themselves for 30 seconds to a minute each, just so as an audience you know who the 6 of us are. So Paul, let's start with yourself.
Thanks, John. I'm Paul Dietze. I'm from the Burnet Institute in Melbourne, Australia, and I'm also the head of the Melbourne office of the National Drug Research Institute there.
So hello, my name is Jauffret-Roustide. I'm a sociologist at the French National Institute of Health and Medical Research in Paris, and I am also a member of the scientific committee of EUDA.
And Katri.
My name is Katri Abel-Ollo. I'm from Estonia. I work at the National Institute for Health Development. I'm a researcher and also the focal point coordinator for the EUDA.
Tom.
And I'm Thomas Clausen. I'm a professor at the Norwegian Center for Addiction Research at the University of Oslo. I'm also a member of the scientific board here at EUDA. And I'm did I say it? A physician of background, yeah.
Hello, everyone. My name is Keith Humphreys. I'm from Palo Alto, California, right near San Francisco, where I'm a professor of psychiatry at Stanford University and a scientist in a veterans hospital.
Okay, well, thanks to the panel members and the preparation they've put together. So the first area that we wanted to look at was, why are established interventions not widely available, and where they are implemented, why do we not see the reduced levels of drug-related deaths at a population level? And Paul, I'm going to come to you first. Whoops, I'm pointing in the wrong direction. Paul, I'm going to come to you first about, we've now increasing research evidence of what works, but we don't always see that being translated into practice, so why not?
Well, fundamentally, I mean, we do have some reasonable evidence around some interventions, but our implementation is terrible. So if we take the example of, say, opioid agonist therapy in Australia, since I've started in my career, it was only until last year that a system that had been in operation since 1985, the participants in the system didn't have to pay dispensing fees that would take up to a third of their income. So a terrible implementation of a system that really is also reflected in other harm reduction interventions that we've had that could work to save and reduce drug-related deaths. So take-home naloxone, the same, started in 2012. It became widely and freely available across the country, technically from the middle of 2022, but it's patchy right across the country. So in New South Wales, I think the situation's much better in terms of gaining access for a range of different touch points, but in Victoria, the situation is very, very limited. So our implementation is terrible, and at least a major component of what's driving the resistance to implementation is a lack of investment, but that's also bound up in the stigmatisation of people who use drugs and drug use more broadly, and that permeates all the way through to the way in which people will engage with services as well. So, why go to a service where you're not treated well? So, as a consequence, I think all of these things come together to work against effective implementation. But the thing that we do need to keep in mind is that almost all of our sort of evidence base and our implementation science base is from high-income countries. We know much less about how to implement things effectively in low and middle-income countries, and it's really upon us to improve that situation.
Okay, so I'm taking away, would it be fair to refer to it as institutional discrimination?
I think absolutely there's institutional discrimination. But the other thing is the evidence base is very thin in relation to a range of drugs that we now are seeing and seeing is much more prevalent than the ones that we've seen in the past. So methamphetamine, our treatments are nowhere near as effective. And there's obviously the emergence of novel synthetic opioids.
So Marie, let me come to you. So similar question, so there are interventions that have been positively evaluated, but then we don't see that impact at a population level. What do you make of that?
My understanding of the situation will perfectly echo to what Paul just said. I think that the overdose problems needs to be considered as a syndemic question, and unfortunately, we only try to tackle the public health aspect, and we don't understand this question as a complex question. So if we want to be effective on overdose prevention, we also need to put a lot of investment on mental health issue, homelessness, poverty, because they are also the drivers of overdose. I also think that the question of stigma is very important, because we speak a lot about the effectiveness of harm reduction tools, for example, and there is a huge literature that has proven that drug consumption rooms, naloxone access, OAT, and also drug testing are effective, But we also need to look at the context in which these tools are implemented. And for example, if you implement a drug consumption room in a country with a prohibitive regime, where people are stigmatized, that will be much more less effective, because people will hesitate to attend the facilities, for example. And I also think that one of the reasons why we are not very efficient on overdose prevention deaths is also the question of the socio-ecological context in which all these interventions are implemented. And we also need to work on the criminalization aspect, because stigma is very linked to criminalization. And if people don't feel being respected when they attend services or as person, all the interventions that you will propose to them will be less effective, and we need also to have much more investment and sustainable funding in harm reduction. And perhaps the last point will also be to address the question as a whole and not to oppose drug treatment, recovery approaches with harm reduction. I personally think that recovery can also be considered in a harm reduction approach, and if we want to be effective on overdose prevention, we need to address all these topics.
Okay. So again, if I can take away some points, in addition to the points that Paul's made, you're reminding us of the societal context in which the behaviors occur, which includes disadvantage and greater concentrations there. And in fact, we were talking earlier about the importance of integrating perspectives around either treatment or recovery of harm reduction. And you spoke eloquently about the French example of it. I'm going to move on from that. Katri, you bring a particularly interesting perspective from not just from Estonia, but Estonia's been such an interesting example with some of these areas. And I guess it could be that with your experience with fentanyls over more than a decade, as well as nitazenes, one could argue some of these drugs are just inherently dangerous in their use and their pattern of use. So the challenge would be, in what ways can you actually reduce harm, or is it just intrinsically harmful? How would you deal with that?
Yes, indeed. We have been facing this synthetic opioid crisis for like 20 years already. And at some point, you are right that we really say that maybe they are too lethal and dangerous, and there is anything we can do actually about it. But the take-home naloxone program has been available since 2013, and with fentanyl, actually, we saw the positive effect there. We were years and years trying to expand the program, but we really around 2017, 18, we saw how the drug-related death cases decreased. But then the nitazenes came, and somehow the Estonia has been this kind of a test laboratory or the trial and error country. For some reason, now Latvia, of course, joined us with nitazenes, but with fentanyls, we were totally alone in the beginning. And really, with this take-home naloxone program, now also CDC says that with nitazenes, it's proved to be efficient. But we always have to keep in mind that the dosage is what they need is so much higher than even with fentanyls. Because my scariest experience during my career has been when 2022 emergency service called me into the institute and said that something really, really weird is going on the market, because we are giving 5 or 6 naloxone doses, and the victim is still in danger. What is going on? And I was like, wow. You ask me, you are the medical specialist, so it was the scary moment. So.
Okay, I'm aware I'm needing to keep you guys to time, and I suspect I'm already the one that's breaching it. So I'm going to move us on to the second topic area that we put together from a sort of consultations across colleagues. So the second area we wanted to look at is whether we're giving sufficient attention to the broader societal and to the broader contextual and the societal drivers of overdose deaths. And Thomas, I'm going to put you in the hotspot first. So we often see drug-related deaths as a problem related to individuals and their behaviors, and that tends to inform our responses. But are we perhaps missing the bigger picture?
Yes and no in a way. I think an overdose death, when it's nearly happening or happening, it's late typically in a process, right? And we do focus then on the individuals and what we can do there with naloxone and those kind of things. But also what we know and see is that it's the end stage of a much longer process and a very difficult situation for many of those who end up in those situations. And that is about housing and poverty and other health difficulties and social marginalization. So there's a lot, yeah, and I think to prevent and deal with the core issue of overdose deaths, we also need to address all those issues with health and social programs and prevent the deaths earlier than what we can do with an naloxone when there's someone on the floor. So yes, I think certainly we need to look wider at it than just the medical bit when people have blue lips, certainly.
Okay. Well, Keith, let me sort of bring you in at this point, because from the panel, I don't expect you to be representing the US, but you bring an understanding of the US experience in all sorts of ways. So we've observed from this side of the Atlantic the dramatic problems of drug-related deaths, not just in the US, but across North America in general. So is that a reflection of some dynamics of the drug market, or do you have any observations about the extent to which it ties in with the discussions we've had earlier about context and setting?
Using my stopwatch?
Yeah.
Go.
It's good.
So my whole career, people have said, the drug problem is not the real problem. There's a root cause that is the driver. Coincidentally, the root cause happens to be what they study, so that's really lucky. And that seems plausible, right? You could see this is an outgrowth of something else. The problem is, empirically, it's very hard to sustain that. There's a great paper by Hare and Jalal in Science looking at over 45 years of drug overdose deaths in the United States, and they chart an exponential curve year after year after year. Some years they're a little up, they're a little down, but it's a remarkably steady curve over periods where the economy was growing and shrinking, where housing was increasing in price, lowering, when there were a lot of jobs, when there were few jobs, when racial relations were worsening, where they were improving, when government was liberal, when government was conservative. So it's a faith people have, but it's just really hard to see it in the data. And therefore, I don't think we should underestimate maybe what seems like the dumb explanation is it has a lot to do with drugs, actually, the drugs that are available. You know, we and Canada, in a very short period of time, about 11 years, increased per capita prescribing of opioids by about 400%. That's going to have an impact. And a very nice study of this is by Alpert, just won an award actually at ISSDP as Best Drug Policy Study of the Year, and showed something really interesting. So the company that was the worst actor, Purdue Pharma, there were a couple states that had such tight prescription controls, they said, we're not going to market there. Those states didn't develop anywhere near the opioid problem than the other ones, and that predicted better than things you think might, like how rural they were, how urban they were, how rich they were, how poor they were. It really was the drug. And same thing now with the emergence of a fentanyl market, which was driven on the supply side. That is a qualitatively different drug, extraordinarily deadly, and the fact that it came there, which is an outgrowth of the fact that we had at that point millions and millions of people addicted to opioids through the healthcare system, has been the biggest killer. So sometimes the obvious explanation may be the right one, which is, yeah, it's a massive increase in really dangerous drugs.
Okay, look, let's stick with that point, and Marie, I'll come back to you on this one, to do with, if we think of the North American experience, where there's more, well, just in the US, there's more than 100,000 deaths per annum, and across the whole of Europe, it's something like 6,000 or 7,000. And how do you think one explains that difference? Is it just to do with different drug consumption patterns, or is it the synthetics that are a big driver of that?
But I think that the fentanyl question is obviously important, but if we compare North America and Europe, and especially my country, France, that I know better, one of the major differences is the state investment in harm reduction, for example, and in drug treatment. For example, in France, we have 500 overdose deaths per year for a country of 67 million of inhabitants. That's too much, but that's quite low compared to other European countries. And we can explain that because we have a very large access to OAT and a very large access also to harm reduction services in France, because we have state investment and sustainable funding. So the drug is important, but the policy also matters, and the response that countries can address to the question of overdose is also important. And I think that the access to OAT is something important, the access to harm reduction. And in France, for example, we have access to buprenorphine and access to methadone, but people have also access to morphine sulfate in the black market, and it works at a sort of safe supply, an unofficial safe supply, and I think that it's also a protection regarding the arrival of fentanyl.
Okay. I'm going to have to discipline myself here, because I think this fentanyl issue still puzzles me hugely, because the challenge of ordering it on the internet from North America is no different to ordering it from here. So I still don't understand why there's such a stark difference, but that's for next year, 2 years' time conference, perhaps. Maria, I'm going to stick with you for moving on to the next topic area, which are what are some of the main opportunities for increasing service provision in this area? So, do we need to reach and involve more people who use drugs themselves and the wider community, or how would you advise we take this forward?
But I'm personally convinced that the involvement of peers, the involvement of people with lived experience is very important. We know that from the AIDS epidemic experience, because if we have in the 80s and 90s been able to implement access to syringes, access to OAT, it was also linked to this civil disobedience, and people with lived experience had a major role in implementing harm reduction. And I think that we need to translate that in the overdose epidemic situation now. We know that there are several programs with peers that works very well. I can mention, for example, in the French-speaking part of Canada, Quebec, there is a program called Profan that is led by peers, and that is very efficient. And what we can see from the literature is that the fact that when people are in contact with peers, it creates a safer environment, trust, and people are also more confident with the information that they share. So it levels, it increases the level of protection for people who will benefit from the peer intervention, but it's also the peer involvement in overdose prevention is also important for peers who deliver the intervention, because it increases their skills and also their self-esteem. And I'm personally convinced that fighting against stigma and creating safer environment and trust for people will will allow them to have a better access to services because they feel being respected. So I'm very, very convinced by the fact that we need more involvement of people with lived experience, but there is also an issue that needs to be addressed, is the fact that people with lived experience and peers who are involved in overdose prevention can also be very in burnout or being very shocked by and traumatized by all these deaths that they have to face, and they also need to have support from other health professionals and to be included in wider communities of health.
Okay. So I'm going to make a slight, I'm going to summarize it but twist it a little bit at the same time. So you've talked about the importance of trust and of the advantage that there is from peer involvement, but I'm also going to say that there's that issue of trust within all services that are provided. So whoever they're being provided by, trust is a crucial dimension which is often missing, and the peer aspect may be one way of dealing with it. I'm now going to use it as a link through to Paul and say, in addition to that, we're in a technological revolutionary age. You know, my watch is buzzing because I've forgotten to turn it off, and all sorts of messages are coming in. Are there technological aspects we should think of?
That's always been the big hope that I've had. So I too have this watch that tells you everything. It tells me my heart rate's actually pretty low at the moment.
Hey guys, I think we can do something about that for Paul.
But it even tells you things like respiration rate and things that it actually can't measure. What's on there is rubbish. So this fancy watch that's gone through all of that development is still no good. And all of the devices that have been sort of proposed that could actually do some kind of overdose monitoring have all failed. We're in the process of testing one that's a little bit simpler, which I think is actually interesting. So it's just an accelerometer that we've tested in the Sydney Medically Supervised Injecting Room, and there's some promising elements to it. And there was recently a publication about one implantable device in pigs in Harvard that seemed to reverse overdoses in pigs. But you know, they're at least 6-10 years away from market, and in the meantime, with 100,000 people dying in the US, we need other interventions, we need to do other things. So I think we shouldn't let the ball drop on that. But we need to be probably prepared for the next opioid epidemic kind of thing, rather than focusing on trying to do it for the here and now.
I mean, I think one can be very critical of ourselves about allowing our sector to be left behind. You know, I mean, my watch, I've triggered it several times in stumbling as I don't see a step and things like that, and it says, "Have you had a fall?" Now, if my watch has that capability built into it, why are we not? The only explanation for why we're not seeing it in our sector is that somehow our sector isn't seen as worthy, and we are part of the community that determines that. So I think that needs to be a resolution. That I'm going to move on from that to Thomas. Just a quick question. That one of the other areas that we'd see, which Marie took us to, was around drug consumption rooms, and you know, you also have drug consumption rooms in Norway. So I guess that there'd be some people who say they're being undersold as an idea, some people that they're being oversold. How would you see that spread of debate?
Well, I think maybe they are both over and undersold, but I think the experience in Norway with drug consumption rooms is that during opening hours there are reductions in overdoses, very few or never fatal overdoses in the consumption room, and during opening hours in the community around there are very few fatal overdoses. So it seems to be working, but it's also an intervention that we have two of in Norway in two major cities, while overdoses take place all over the country. So it comes with limitations, and it's not going to solve the whole problem. And we discussed earlier on, you know, if people come to the consumption room because they know their staff members that will look after them and take care of them, will they then push their drug use behaviors even more than before because they know there's someone there? Little evidence may be pointing to that, but then what happens when they've been to the consumption room twice during the day, but then the 2 last doses they're taking in the evening, if they continue with the same practices they did in the consumption room. So there are difficulties with this, although it sounds like it's logic, it's going to work. We don't know on a population level that it actually changes our overall numbers and the fatal outcomes.
Okay. That's really helpful. I'm now going to move it to an uncomfortable area for most or all of us, which is, you know, why aren't scientists and researchers doing better in this space? You know, and the evidence base, you know, is it actually fit for purpose, especially when we see the changing nature of the problems with potent synthetics and stimulants and more complex patterns of drug use? So, first person I'm going to put in the hotspot, Katri, is yourself. You know, do we know enough about the changes in consumption patterns and how that relates to drug-related deaths that we're focusing on now, or do we need better study or different study?
I think that we don't need know enough because the drug market is so rapidly changing. And for example, with Nitasens also, what data sources what we had was administrative data from the seizure statistics. Then we did quickly the syringe residue study to understand actually what's going on, because when we ask from the people who use drugs, then they say that they use fentanyls. But as from the police reports, we knew that fentanyls is not available in the market. So the syringe residue study actually revealed us that these are Nitasens, what they call fentanyls. And that is a very, this kind of problematic topic in Estonia also, because our first thought was that we need something like drug checking service, because the users themselves are very interested what they use. But it's not, according to Estonian law, it's not possible to do that. And supply reduction field is not also eager to have this, because they don't actually understand correctly the need for it. But actually, also, if we need an early warning system for the people who use drugs, then the one source would be also the drug checking service. I don't care if it's the mini grip bags or something, but the substance should be in there, and forensics should analyze it very quickly and say what's going on, because otherwise our users, they don't know what they use. They use it as a heroin and fentanyl or something, but Nitasens, they are totally different thing. And currently we just rely on the administrative statistics and some studies, what takes like 3 months to analyze it.
Yeah. So the reason, it seems to me you're an important, particularly important contributor to this debate, because we can look to Estonia. You're a country that is a sort of petri dish for drug problems.
Yes.
Yeah. And for example, you have 15 years plus of knowledge about extensive fentanyl use, and we rely on you to contribute that understanding when actually it's all of our need that you're now there to address. I think that's something we have to, it's very much an EU area and challenge. I'd say EU in that broader concept of EU and the other associated countries. But I hope we take that away as one of the messages. Keith, let me move to you about this issue of the evidence base, because most of what we've done has been around specific drugs and specific substances. I mean, what do you think? Have we got good enough evidence, or do we need different evidence?
Yeah, I think we don't quite yet know what we're doing. So I have a colleague, a terrific colleague named Dr. Coffin, and I think you've got to be a good doctor to get patients when your name is Dr. Kaufman, Dr. Philip Kaufman.
Especially Phil Coffin.
Yeah, Phil Kaufman. Yeah. He's terrific, and I don't know if he's here, Phil. I love you if you are, but he likens it to an antibiotic-resistant infection. That's what fentanyl's like. In other words, the stuff you've been doing for years and years and years all worked great, suddenly stops working, and you don't quite know what to do. And I think we are there for lots of things. And since a lot of you are mercifully in countries where you wouldn't see people addicted to fentanyl, let me just focus on one way where they're different. So when I started my career, just the planets had formed, the dinosaurs were on their way out, and I was an undergraduate. And I would meet people who were addicted to heroin coming into treatment in Detroit, and they might use heroin 5 or 10 times a week, okay? So imagine that. I meet people now anytime I'm up in the Tenderloin, which is sort of the toughest neighborhood in San Francisco, who use fentanyl 5 or 10 times a day. So just that one difference, 5 or 10 times. So what's it like? Well, a lot of the people who were addicted to heroin had jobs, still with their families, reasonably functional, were still thinking about their life, could sort of get away from that. If you're using fentanyl 5 or 10 times a day, it's very hard to do anything else. You're always in withdrawal, getting out of withdrawal, getting high, falling asleep, waking up in withdrawal all day long. So things like, can you just pull it together enough to even make sure you get enough food is really hard. Can you, see what's going on, have the time to reflect on your life and where it's leading is really hard. Getting people engaged in treatment is really hard. It's not as simple as just give them a dose of methadone that'll hold them for 24 hours. It usually won't. It also changes, I don't suppose there's many people who do on the enforcement side, but it's, I think, worth noting, it changes drug markets a lot. The most common question I get asked by journalists is, why does anyone sell fentanyl when it kills people? You can't make money when you kill your customers. Well, the most profitable product of the 20th century was a cigarette, okay? You can make a lot of money when you kill your customers, as long as you make the money before they die. So fentanyl's killing people, we estimate maybe 5 times high the risk of heroin in the United States, but again, you're selling it 5 to 10 times a day. So it's still lucrative. This is awful math, but these aren't nice people, right? It's still very lucrative from them on the sell side to keep doing this. So they're not going to stop doing it out of fear. We're killing all the customers. They're not going to make any money. Sorry. They're making an extraordinary amount of money. I'll stop there.
Okay. I think it's useful. I'm going to switch to a different aspect of it now to do with what areas where we should be able to give clearer answers. And I'm going to go for something extremely simple to do with medicines and their reversals. And I'm going to take the issue of, the discussion that we have internationally about what doses of naloxone should be given. And I imagine most people in this audience are familiar with this, but let's be quite clear. Of the different products of naloxone that we have around the world, you start off with ampules, which are 0.4 milligrams, which have been widely relied on by ambulance crews. Across Europe, we have 1.26 milligrams or 1.8 milligrams. The US has 4 milligrams, it has 8 milligrams, now has 12 milligrams, I think, or certainly in that zone. And I sort of feel as a scientific and clinical communities, we need to get our act together about what do we think the right doses are. So I could go to any one of these, but I'm going to start with Paul.
I want to jump in here. So the 400 microgram dose that you were talking about, the ampule, so I can't find anything other than a historical kind of accident that it came into being, because there was also the 200 microgram one and a 100 microgram one that seemed to have fallen out of favour. Right. And so the 400 seems to be a bit of an accident. And, like when it's used intravenously, people generally tend to titrate very small doses and so on. So for intramuscular injection, the dose is... Again, it's kind of a titrated thing of relatively small doses. With intranasal, it becomes much more complicated because the onset of action is later, and you really don't want to load someone up with a whole lot of naloxone that they don't need. We did some of the randomised trials of intranasal versus intramuscular naloxone, and we were getting massive responses to very low doses of naloxone. So people who were obtunded for a significant amount of time were responding with, as little as 800 micrograms intranasally, which is much less than what they're talking about in the US. And in one of our trials, we gave 2 milligrams in 5 mil. We estimated that about 4.5 mil was wasted because it was it lacked concentration. So low doses do work. And, the point that was made before about needing higher doses, well, we've needed higher doses all the time. So in analysis we did in, I think it was about 2002, there's massive variation in what paramedics were given, right up to 6 milligrams, depending on what other drugs people might have had on board and so on. So we really need to think carefully about our doses. There's not much, especially in the area of intranasal naloxone, that's been done with actual overdoses. It's always just in healthy volunteers and looking at blood concentration. So I think there's so much more work to do in that space. And with 100,000 people dying in the US, there must be a heap of non-fatal overdoses that are being reversed. There should be better data on what naloxone doses are needed.
That's really useful. And just again, and apologies to the 90% of the audience who know these numbers and such well, but the sort of rough rule of thumb is nasal sprays, about half of it gets absorbed. But the particularly interesting point you say about your own earlier work and other people's work with what I'll call the improvised nasal sprays is that they were essentially an inefficient way of giving it, and yet they still brought around resuscitation. So low dose, for many people, is sufficient. So how does one reconcile that with the need? If anyone hasn't read it, there's a very interesting recent paper by Russell and others about looking at how does one have appropriate compassionate use, and it should be part of the debate we're considering. So, Katri, because you've got this experience of how does one handle the stuff that everybody else is now worrying about. Any great insights for us? Yeah.
I can say that from the emergency service, they claim that they use 5 or 6 doses what they used to, like regular doses now it's 6 doses, and sometimes even with 6 doses it doesn't help so well as they expect. But when we talk about take-home naloxone, then we have the pre-filled syringes and we have the nasal format. And also our users say that the pre-filled syringe works better. They trust that more, but it's not so available as the nasal format. But with nasal, they need also like 5 times they have to use that. But yeah.
Okay. Well, I mean, these are part of what should be part of more of an active debate. I mean, any other crucial aspects at this stage? Yeah.
Perhaps regarding naloxone, beyond the question of doses, I think that acting on the question of social isolation is also something important, and that's why I think that also drug consumption rooms may be effective on preventing overdose, because people are not alone when they use, and professionals can act on and reverse an overdose when it happens in a drug consumption room. And also the question of training, that is very important in my country. For example, people are not enough trained by using naloxone, and that's why the peers programs may be also very important to have a wider community involved in naloxone access and dissemination.
Okay. I'm going to add a point in here because I'd be a strong supporter of naloxone provision and pre-provision, similar to the EpiPen or a defibrillator logic to it. But I do worry that we focus so much on the naloxone as if that's the only intervention. And essentially, we're needing people to pay attention to the person who's in a medical crisis and to assist their breathing and to call an ambulance. And, and if naloxone is there, that can be the extra. But I worry that we're in danger of creating a situation where people think that if naloxone's there's nothing you can do. And as part of our citizenship, we need to realize there's a lot of interventions to be done to assist breathing, and naloxone's a real bonus.
I totally agree. We need to be also careful with considering some biomedical tools as magical, and we need also to have a better global view of the question.
And that's probably applicable across all the medicines that we have enough of. No, I agree. I'm going to try and squeeze one more question in before we get to the last section. So Thomas, I want to take you to the issue of prescription medicines that we use in treatment. And they, in fact, I'm asking you this question on the day that England's just released its drug-related deaths data, and prescription medicines prescribed in addiction treatment are prominent within those deaths. How do you see the balance between the characteristics of the treatment drug and their contribution to deaths?
Yeah, it is a tricky dilemma. The medicines we use in opioid agonist treatment, they are potent opioids, and people can overdose from them, particularly if they're not used to them and they are out in the community. So there's a balance, both providing easy access to treatment to as many as possible. We would want 80% or something of the target population in treatment or more, but also providing it in a safe manner so that it doesn't reach minors or others outside of treatment. And we do know in Europe, in the UK, in Norway, that methadone, for example, causes death and contributes significantly to the national numbers of overdose deaths. So that balance is tricky. I think every treatment provider needs to deal with it kind of daily. But in saying that we need to find that balance, in a way we also accept that some people or some of the medicines will be diverted or will reach others and even die from it. So it is, but it shouldn't be too many. There shouldn't be many at all. But otherwise, if we want no such medicines to be in the wrong place, then we will also have people not staying in or being attracted to treatment. So this balance is a tricky challenge. And I think every provider and every center needs to work on it continuously, basically. But it is a balance between access, safety, and the quality in the services. What do you actually provide in addition to the medicines as well? So I think this is a challenge.
And certainly in the UK context, I think it's still correct that the majority of those deaths, for example, methadone deaths, are actually of people who are not the person to whom it's prescribed. So there's that tricky challenge for clinicians about how do you have a treatment that's easily accessible and doesn't have a demand that means you lose the person from treatment, while at the same time having that wider safety. And it is that difficult space of balancing those. As a clinician, I'll always feel, well, I know it's not my patients, and they're not my patients at all, but I know it's not my patients who are looking at it, it's that doctor down the road. But I guess it's intrinsic to the nature of the field. So,
but one of, not the solutions, but one of the good things that we've seen recently are new medications that don't really get diverted. The long-acting buprenorphine formulas that you take and they can last for a month. So we have also seen progress in the field that there are new medications coming. But it is a challenge, and typically those who die from diverted medications, they aren't patients, but someone else outside. It's tricky.
Yeah, and from that point of view, technology does bring us some advantages. That the idea, not just the specific long-acting buprenorphine, so the European one of the Buvidal or the North American ones of the Sublocade, but a whole notion that the medication basis of treatment might be separate from the wider intervention. It's been such a dominant influence, hasn't it, I guess? So, I'm going to... Guys, we are roughly on time, so this is extraordinary. So the last point I wanted to go around each of us is to sort of say, in each of our views, what do we think are the most important research gaps in this area? So I'm going to start off this end. So Keith.
So a strange thing to say on a panel focused on drug-related deaths is I think we often focus too much on drug-related deaths because they're easy to measure. And they become the sort of the sine qua non of this is what we're supposed to do. And of course we don't want drug-related deaths, but making that the goal of drug policy is a bit like saying our COVID strategy is to really improve the intensive care units so there's more ventilators and better oxygen. So if that's all we did, we never would have gotten through COVID. Someone needs to be thinking about prevention, about treatment, about environmental interventions which are harder to measure the effects of. We don't have good measures in most countries of just simple things like how many people use each drug, how many people are addicted to these drugs, how many people are initiating. And so if we had that, that would help us fill out the dashboard so we're looking at lots of important things that are not going to change overdose deaths this year, but could dramatically improve the health of the population over the next 10 or 20 years. And I've spent my career helping people who are addicted, so I want that help to be there. I also know if that is what we just do, we wait for people to get in a lot of trouble and then we throw a ton of resources at them, we will be doing this for the rest of our lives. And I would like to not have us be in that state the rest of our lives.
Okay, so let's come round the arc. So Thomas, next yourself.
Yeah, two things. I'm hearing here that we should learn from our neighbors and others, the international community. I think it's important, and sometimes we can. But I think the key, actually, to prevent overdoses are a knowledge of the local. So local-based research to know what's your problem and how can I address it. So maybe I can learn stuff from the US, yes, and the fentanyl, but we don't really have fentanyl. So I need to know what's my issue and try and deal with that. So I'm actually advocating for the local knowledge and then to broaden it and share it, of course, with colleagues. And I agree with Keith. I think we should invest more, actually, into preventive research and study what's going to happen when we see and experience more drug-liberal societies. How will that impact and how can we address it in the future? I think there's a lot of research to be done on the more preventive side of it.
Katri.
Yeah, I agree. I have two points. One is synthetic opioids and treatment. We really should invest more because we guess that they are similar to opioids and we need to just increase dosage or something like that. But it's really trial and error currently and we really need more information. And the second part is I guess really need to listen more the voice of drug users also. Because currently I'm analyzing the interviews with nitazeene users and it's really, really eye-opening experience. So how they describe their own harm reduction measures and how they do it. So really I have a feeling that 10 years I have been in the dark age, something it's really lightening.
Yeah, no, I think it's a hugely valuable trick to pass on to one's colleagues to actually listen to some of the population. I guess it's what clinicians have learned over recent decades, that there's a different perspective to the experience of being in that relationship from just the side of the desk where the clinician's looking from. So it's Marie?
So that's a complex question, so that's very difficult to have a good response on how to do better, because a lot of countries try to do their best, and especially a lot of harm reduction providers, drug treatment professionals. So the first point for me will be not to address only the consequences but to address the causes and to address this question at whole and to implement effective policy on the social aspect and especially to address the question of homelessness and also mental health that are, and social isolation that are very important drivers of overdose. So that will be my first point. The second point that is very important for me is to stop to oppose harm reduction, drug treatment, and recovery, because only single approach will never solve the problem. So we need to envision it at all and to consider that people can need to have harm reduction, access to harm reduction to be alive, and if you want them to recover at a moment of their life, they need to be alive. And that's why we need to have more investment in harm reduction, but also in recovery approaches and also in drug treatment. And perhaps my last point will be more focused on people with lived experience and people who use drugs. If we want to have effective policy, we need to reduce stigma. That's something very important because we need to build the trust between people and the providers and the drug treatment providers. And if we continue to stigmatize people who use drugs, we will have difficulties to make them confident to access to drug treatment services or harm reduction services. And perhaps the last point will be to...
That's your second last point.
Yeah, sorry, I speak too much and I have several last points. So my final last point will be to have alternative as prohibitive regime, because we know that in North America, for example, the prohibitive regime showed its limits, and that's very important to promote probably decriminalization, as Portugal has done, and Portugal has very good results on overdose deaths, for example.
Okay, and
Sorry.
Paul?
I agree with what all the other panellists have said, so I'll take a slightly different perspective. I think in our cohort of people who inject drugs, there's a group of people who've been injecting heroin for a very long time. They've never overdosed. They're behaviourally identical to the other people who do. In the cohort in Vancouver, Vitus, which has been running for even longer, there's people in the fentanyl environment who never overdose. There is something about those people that we really need to understand in order to develop up some alternative strategies to the ones we have.
Yeah, and that's such an interesting example, if I can just pull that one out, because it's what you'd expect to see if one's looking at COVID resistance or other areas, and yet it doesn't come up in the conversation. So, thanks. I think I've got 2 minutes that I'm allowed to. I wanted to add in the issue of near deaths that occur, because I still remember when we started doing some inquiry about deaths, I was shocked how many of the people that I was seeing in treatment as a clinician, that when I asked about it, then said, oh yeah, I've had an overdose and I've been present at someone's overdose, and it's so prevalent, and the cumulative effect should at least be explored. Does it matter or does it not matter? You'd predict that it would be worryingly damaging. So that's one. The other area, I think, which has been an extraordinary phenomenon, is the wider intervention workforce. When we started the work around take-home naloxone, I would never have thought of firefighters and police and such, and yet those workforces in some parts of the world have become very active parts of the response, and we probably need to think differently about how to harness that. And my final point is one about, I really do think we should expect stronger science. There are different ways of studying different challenges across the whole of medicine and healthcare and society, and we shouldn't be pushed down to the cheapest, lowest level methods. We should be looking at what's the best way to study it. And as my final point, I'll pull it back to one of the very first harm reduction conferences and one of the first books that came out around harm reduction was From Faith to Science. And a lot of our area, personally, I feel there's too much loyalty and commitment to doing what I do and defending it. And we all need to be much more open to listening to criticism, thinking about whether it's applicable to how I work and where I work, and looking for ways in which we can get a better answer to move it forward. So From Faith to Science is what I hope you took away as a message. And at that point, I'd like to thank an extraordinary number of people who've obviously not got enough going on in their lives that they could enjoy themselves in other ways. But to thank you for sharing that sort of sadness with us, and to thank the panel here. So thank you very much indeed.